Good morning. Thank you so much for having me here to give this talk on the prevention of cesarean deliveries. I thank the organizers of the meeting for inviting me, and I know my friend Dr. Graves is here. I was really hoping to see you all in person. It was definitely the hope, but obviously the global pandemic had other plans for us. This is a talk I've given a few other times before, and I'm going to try to fit in the time. So let's get started. I might talk a little fast to save some time, and I apologize in advance if that's the case, but hopefully we'll get through. So this is the title, Cesarean Epidemic, and I talk about the etiologies of this epidemic, outcomes, and potential solutions. I have no disclosures related to this talk financially, other than the fact that I am an obstetrician and I'm paid a little bit more to do C-sections and vaginal deliveries, although I don't receive that payment myself. My institution does. I'm going to give a talk on the background of cesarean deliveries and things and why we would care about the C-section rate. In other words, what bad things might happen. And then we'll talk about why the C-sections went up potentially. And then we'll talk about maybe things we might do to lower that rate, approaches of that and what might happen. Okay, so 2019, which is the last year we really have good data for in the US, the C-section rate was 31.7% of all deliveries, 2019, okay? It peaked in 2009 at 32.9%. When I first gave this talk 10 years ago, we were just at that peak. And that matters because that 32.9% was about a 50% rise over the prior 15 years. Okay, so it went up, it's kind of leveled off, it's even gone down a smidge over the last decade. And here you can see a kind of in graphical form of that, basically this rise is VBACs, right? So VBACs were low and they went up in the 90s and then they went way down. And then this is the overall C-section rate. And you'll notice in the early 90s, they went down for a little bit, but then this is what I'm talking about. They went up about 50% and then kind of leveled off, right? And you can see that in the more recent years that it is kind of leveled off, 31.9, 32.0, 31.9 of all the different groups. VBACs are actually starting to be on the rise again. This is pretty significant, actually 12.4 to 13.3%, but it's slow. It's very slow. Around the world, we can see that actually, while back in the late 80s, we were number one, go USA, we had the most C-sections in the world. And actually, we are not the highest rate of C-section, and that C-section is actually going up everywhere. Even little old Netherlands, who has got very tall people and low C-section rates, that C-section rate has gone up over the last bit of time. And in the modern world, Italy's got a very high C-section rate, higher than ours. Portugal. We know that China and Brazil both have higher C-section rates than we do. So it is a worldwide issue. Okay. Now, why do we care? If the C-section was just kind of beaming the baby out, what's the problem? But it isn't. It's making a surgical incision both in the mom's abdomen and in the uterus itself. Okay, and that has short-term and long-term issues. Okay, short-term, we have the classic kind of surgical issues: surgical infections, infections inside the uterus, increased risk for hemorrhage, and then injury to local structures, right? Bladder injury, and then of course that individuals who have a cesarean delivery have a higher risk of having a DVT and then a PE, and a higher risk of dying from PE than someone with a vaginal delivery. And Steve Clark kind of enumerated these differences in mortality in a paper about 13, 14 years ago now in the Gray Journal. If you look around the world again, this is a study from JAMA from about 5 or 6 years ago. Here are C-section rates compared to maternal mortality around the globe, right? And so if the C-section rate is well below 10%, this is a C-section rate of 3-4%, the maternal mortality rate in that setting is very high. So initially, C-sections are very, very powerful. They prevent bad things from happening, right? When you go from a C-section rate from 3% to 10%, you reduce the mortality rate by tenfold, right? When you go from 10% up to about 20%, it still goes down, right? Overall C-section rate. But look at the flattening. When the C-section gets to about 20%, it is just flat, flat, flat. When you go up, then here's a country at 55%, okay? The US is somewhere around here, right? 32%, okay? That there is no benefit in the maternal mortality rate. Okay. What about the babies? Well, similarly, neonatal mortality rate goes down to about 20%, and then it just flattens out, that the babies don't have any benefit from these C-section rates of 55%, 50%, 40%. Okay. So that's in the current pregnancy. What about the next pregnancy? Well, in subsequent pregnancies, now you've got a history of cesarean delivery. So of course, there's an increased risk of another cesarean delivery, right? That's the most common indication for a cesarean delivery, is a prior cesarean delivery. And so you've got all those concomitant risks in your next pregnancy. But we also find some other problems. Okay, we find an increased risk for unexplained stillbirth. If you've got a prior cesarean delivery, there's a nice paper in Lancet by Gordon Smith from about 15, 18 years ago. And of course, we see that individuals with a prior C-section have an increased risk for uterine rupture if they have labor. Even if they don't have labor, it's increased risk. And in fact, it's one of the highest risk ratios in medicine, okay? Someone without a prior C-section undergoing labor has a risk of uterine rupture somewhere in the neighborhood of 1 in 20,000. Okay. Someone undergoing labor with a prior C-section has a rupture of the risk of rupture of the uterus of 1 in 200. 1 in 20,000 over 1 in 200, or 1 in 200 over 1 in 20,000. It is a 100 to 1 ratio, right? A relative risk of 100, 100-fold increased risk of a uterine rupture, which is a bad thing if you've got a prior C-section, right? So, and we cause those. That's an iatrogenic cause of uterine rupture. Okay. And we know if you have even one, but multiple C-sections, you end up with high risk of previa, accreta, that leads to hysterectomy, hemorrhage, and higher risk of the mom dying. So we've really increased the risk in subsequent pregnancies. And I think it's an important thing, because we don't consider that incredibly well when we're counseling and managing the current pregnancy. So what are the effects of a current cesarean delivery on future pregnancies over time? And so we modeled this. We worked on this model about 15 years ago. It was published in 2011, about what would happen to the population over time. And we showed that the baseline of the model was in 2006, that the baseline risk of maternal mortality at that time was 600 out of the population, and that this would go up by the year 2020 about 10%, or 12, 13%, 676. And you say like, it's only a difference of 76, but for maternal mortality, which is a very rare event, that's 76 more moms that are dead, families that don't have their mom. I mean, it has impact. If you quantitate it in terms of previas, it's another 4,000 previas in the US. We've all seen these accretas, right? Another 3,000 accretas. And this was assuming a steady rise. Well, we didn't get a steady rise, actually, right? We actually leveled off. We leveled off in about 2010 or so. So we kind of rose to 2010 and leveled off. Well, even then, and that was even then you'd have 40 more mortalities, and that's because the cesarean done in 2006 influences the risk of a repeat C-section in 2008 or 2009, which then leads to an accreta in 2012 or 2013, right? So there's this downstream effect, and that's what we see. So why did the C-sections go up from 1995 to 2010 so extremely? Okay, and so the first thing we point to is the changing demographics of the obstetric population. The women we care for are older. These individuals are more likely to be obese, and there's certainly been an obesity epidemic. If you look at the CDC graphs of obesity, the states like Indiana, West Virginia, some of the states with the highest rates of obesity had rates of 15 to 20% in the early 90s, and they were the highest. Okay. And now our lowest states of like Colorado are above 20%, right? And the whole country is above 30, 35%. So we've really seen more than a doubling in the rate of obesity. Absolutely, absolutely. But let's not blame the moms, right? This is not the biggest driver for cesareans, and I'll show you some data. Well, maybe it's their preferences, it's what they want, right? And for a while, we really thought that it was this too posh to push, and women were choosing C-sections. That appears to be a very, very small percentage of the C-section issue. So I point to these last two bullet points of the environment in which we practice, and it's not always about the medical legal environment, but the environment in which we practice and the incentives. And when I say incentives, I'm usually talking about economic incentives, which are not always about money. Sometimes it's about time and time pressures, and we'll talk a little bit about that. Okay, so if you look at C-section rates by maternal age, okay, they are different. They're higher in women over 40 than they are 30 to 39 over 2029. They're higher. But look, they all went up. They all went up. So we can't just blame the demographics in terms of age. Here's race, ethnicity. They all went up, right? It wasn't just the changing demographics of our population, okay? And here's another looking beyond that, again, you see this kind of leveling off in all the racial ethnic groups, okay? What about maternal preferences? And so there's a paper from about, now it's almost 20 years ago, wow, that looks at trying to estimate the incidence of cesarean delivery and maternal requests. This was an acronym that never really took off, CDMR, CUDMR, I guess it's pronounced, CUDMR. There's some acronyms that just don't work, CDMR. But this is elective C-section, right? Cesarean delivery and maternal request. And Dr. Wax estimated that it could be as high as 4 to 18% of all cesareans, okay? But the problem is the way that the study was done, it was using ICD-9 codes, and it was like, if there wasn't an indication for the cesarean, he said, well, it could have been a CDMR, but we all know there's undercoding. So it doesn't appear that it's anywhere near that high, okay? And the NICHD asked us to figure out whether there was a large demand around the country. Around the globe, interestingly, there are, it does appear that there's greater maternal preference drivers, okay? And we know that Chile's got a pretty high rate, Brazil. And so actually, my research group went to Chile a while back to study this issue. So in Chile, the health system is that if you have wealth or any kind of means, you see a private doctor, and all the doctors are in solo practice generally, okay? And if you are uninsured and don't have wealth, then you go to a public clinic and see the midwives, okay? And the C-section rate in the private sector is like 80 to 90%, and the C-section rate in the midwifery practice is 9%. And so you might say, well, these women are different, they have different preferences, that must be what's driving it. And this is interesting. So we asked the women that we studied what they wished for, what they wanted. And this is the public clinic, this is private practice. This is an order of magnitude of threefold in terms of wealth, okay? That the average income of these individuals was more than, sorry, not three, I apologize, three orders of magnitude. So like 1,000 times more, okay? The income of these individuals 1,000 times the income of these individuals. And look at their preferences. They are essentially identical. About 80% of women, when you ask them, would say, I'd like to have a vaginal delivery. About 10% would say, I'd like to have a C-section. And 10%, there's no real preference, no strong preference. And of course, most of the women that would choose a C-section already had a prior C-section. Okay, so isn't that remarkable that we think it's the women and these different socioeconomic factors and all these things that are driving, but they really didn't appear in Chile to be very different. Now, what other things might drive? And this is a nice paper out of the Harvard School of Public Health. These, by the way, some of these are JDs. They have MPHs, a lot of them, but they're JDs. This paper looks at differences by state and tort reform and how it affects the risk for VBAC, total C-section, primary C-section. You can find that if, for example, states have caps on damages, on punitive damages or non-economic damages, that there are higher rates of VBAC and lower rates of total C-section. Okay, so if they have caps on damages. So there are social policies or medical legal policies that can affect C-section rates by state. Well, we found this paper because we were actually interested in this very question, and we wanted to look at it over time. And this is a paper that's only been presented in abstract form. We've never written this paper, which is embarrassing. We found that, interestingly, the states with and without caps on awards, medical legal awards, had no difference in the C-section rate in 1990. But as you went to 1996, when we were lowering the C-section rate and driving up the VBACs, the states with caps on awards went down more rapidly. And then when it turned around, they kind of kept that gap, but actually more recently that gap even widened, that the no caps. And I got to put down on my checklist, we need to redo this study and finish it up. So economic incentives, I always say that the economics, and I have a background with economics, and is not just about money. It's about how a human maximizes their utility or their happiness, right? And for doctors, it's often is not about money. It's actually about time, right? Because that's our big shortage. Do we have more time, right? And so you can trade time for money. It is true, but we usually don't need more money. We need more time. Well, let's think about C-sections. We're paid around the same. And I mentioned earlier, I mean, the reimbursements in most areas are 10, 20% higher for cesarean delivery. I don't believe that most clinicians are thinking about that. I'd be surprised. It may be in some settings that you know about it, and that's fine, but mostly not. And the reason why that reimbursement and the RVUs are a little more for C-sections, it takes more time to do it, okay? But let's really think about the time it takes to do a C-section, okay? If you do an elective C-section, you get it scheduled for like 8 o'clock, and patients in the OR, you don't have to be there until the patient's anesthetized and they get their spinal. And then it's about 8:25 or something like that. You roll in and you start your C-section. If it's a nulliparous person, someone without a primary C-section, without a prior C-section, you are done in 30 minutes, okay? Vaginal delivery, well, if they're about to crown, if that's when a vaginal delivery start crowning and baby's out in like 2-3 minutes, you might have to prepare a little second degree, yeah, maybe it's 15 minutes. So powers that be are like, well, C-section takes longer. Okay, but wait a minute. For a scheduled C-section, when does it really start? Well, actually, it really starts when we said. I mean, yeah, I guess you should probably come in when the patient doesn't say hi. So maybe you got to pop into the hospital and say hi at 7:45. But when did the vaginal delivery start? So a vaginal delivery at my hospital that happens on a Sunday probably started more likely than not on a Friday. Okay, even in spontaneous labor, right? Because maybe that patient, that nulliparous patient, came into triage Friday night for a 2-hour triage visit, but was actually really in prodromal labor, right? And came back Saturday midday in real labor, but still early latent phase, and wants an epidural, so stuck around, and then slowly progresses to 7 to 8, and you know, by 9 a.m. on Sunday is complete, then pushes 4.5 hours like they do. And so you're doing that vaginal delivery after 24, 26, 32, 38, 48 hours of management. And you weren't at bedside the entire time, but you had to know about it, right? And the nurses were at bedside. So there's a lot of resources that go into a vaginal delivery that we don't fully appreciate, I think, and certainly our health system does not, just reimbursements. And then you add in our anxiety over the kind of perfect baby situation, you know, a single deceleration on that fetal heart rate tracing. And man, the pressure to do C-sections is very strong, okay? Well, all this work led us to be concerned that we should probably try to figure out a way to lower the C-section rate. And some people that are much wiser and smarter than me kind of led this group at the Society of Maternal Fetal Medicine meeting back in 2012 to think about things we might do. And when you looked at the big drivers, right, it was inductions of labor, it was first stage arrest, second stage arrest. So they came up with some guidelines, right, that we should not necessarily just cut people rapidly after induction of labor. You should, you know, wait at least 24 hours, that you should wait a little longer in the first stage, wait a little longer in the second stage, right? That's what they came up with. Well, will those things work? What can we do? Let's go through some things that I would suggest we could do, and maybe what the benefits of those things might be. Well, VBAC. So VBAC worked. We did that in the US in the early 90s, late 80s, early 90s, and it works. Okay, here's a VBAC rate that went from about 18% up to about 27%. At the same time, the total C-section rate went down. Okay, even the primary C-section went down at that same time, by the way, which at that time was the first time and the only time in a developed country that the C-section rate went down. The only country to kind of mirror that actually is China over the last 10 years, which has lowered their C-section rate. But otherwise, this is an unusual phenomenon in the modern world. Okay, so VBAC, we can do this. Okay, and actually that would really impact the total C-section rate. Okay. We estimate that, you know, half of the folks had given birth every year are multips, about 20% of them have a prior C-section. And with a VBAC success rate of about 70% and 400,000 prior C-sections, that adds up to TOLACing about, say, and let's say you TOLACed, you know, 50% of them or something like that, then that adds up to about 112,000 vaginal deliveries. And so if you just went from, oh, sorry, it was currently 10%. If we went to 50%, that was what that estimate was. And so that would reduce our C-section rate from 31.9 down to 29.1%. That's a big drop in that bucket, right? That's a big drop. So VBAC, if we just get back to a VBAC rate or trial of labor rate of about 50%, a VBAC rate then it would be about 35%, right? You could really make a difference. Will we get there? I don't know, but it would make a large difference in C-sections. But most of the other suggestions are about primary cesarean delivery. So breaches. Well, I don't think we're going to make a dent in the C-section rate by doing breech deliveries. I will tell you that right now. There's just not enough folks that are comfortable with doing breech deliveries. So it's really going to be turning the breeches to cephalic. And that actually we can do. Now, it's a little frustrating because, right, I mean, the success rate from a lot of people is somewhere in that 50% range, and you get maybe a little better and you get 60 or 70, but it isn't 90%, right? It's not, it's really a coin flip a lot of the times. It is improved with earlier gestational age, greater amniotic fluid, which goes along with earlier GA, but it also includes with regional analgesia. And I would ask you, how many of y'all use a spinal or an epidural for your versions? Many people don't. In the institution I worked at in San Francisco for a decade, what we would do is if you failed the version at 36, 37 weeks, when you brought them back for their planned C-section at 39 weeks, we might try again. But the problem is when you try again at 39 weeks, well, now the baby's bigger, the amniotic fluid measurements are lower, later gestational age. And so you'd fail even then. But sometimes we'd flip those kids under anesthesia. What I do now is that we'll try without anesthesia. And there are those moms that really tolerate the procedure very well, but there's others that tense up. If they tense up, I say, let's plan on getting you a spinal because that'll really relax you, reduce the pain, and the kids move much more easily. So what's the benefit of that? Well, there actually are studies, and certainly if we just would try to divert the breaches, well, you'd prevent about 63,000 because there's 200,000 breaches a year. You'd expect that you prevent about 63,000 C-sections. Okay, that's assuming a 50% breech success rate and a cesarean delivery of 30% of those avert, because it's a little bit higher risk of women that are averted. A number need to avert a C-section, 3. You'd have to do a trial aversion in 3 individuals that are pregnant to prevent 1 C-section. So that's pretty good, and we drop that bucket again. And these are primaries. What about labor dissociation? Well, there's some big numbers here, and as we all know, that historically we use this Friedman curve, which was kind of more sigmoidal, and more lately, after the work of Jim Zhang and others that have worked on labor curves, but Dr. Zhang really led this work, which has a different shaped labor curve. It appears that the true active phase of labor in many people is at a further dilation than we previously thought. That there are certainly those that zoom right along, but on average, there are others that take longer, and we need to be patient in those individuals. And so if we extended this diagnosis of active phase arrest, right? Active phase arrest is a common indication, which used to be 2 hours. If we extend it to 4 hours, and I assume many of you are doing this now, and this was based on some of this really elegant work by Dwight Rouse and colleagues at UAB in 1999 and 2001. And they showed in 2 studies that they could prevent about 60% of C-sections by just having people wait 4 hours of no change as a diagnosis for APA instead of 2 hours, okay? So you really can make a difference. Well, wow, there are about 300,000 C-sections done for active phase arrest every year. And if we just said we'd prevent 60%, well, we present 180,000 primary cesarean deliveries. That is a huge drop in that bucket, okay? And that's a lot. And the number needed to avert is now 2. If you just are willing to be patient for at least 2 more hours, you'd prevent 1 C-section for every 2 folks you're patient in. What about second stage? Well, we used to have these rules 1, 2, 2, 3, an hour without epidural, 2 hours with, and it was kind of like once you got to that edge, you were like, well, it's been 3 hours. It's time to either we can play out with forceps or it's time for a C-section. Once again, I will say there's not really good reason to intervene on someone operatively unless you're concerned about the fetus. Okay. In terms of surgical, in terms of cesarean intervention. Certainly if a mom's getting tired, it'd be reasonable to do a forceps or a vacuum. But what about just giving people more time? And once again, let's look at that. Well, what about giving people a little more time, an extra hour? And amazingly, Dr. Gomofsky and Dr. Begala conducted a small randomized controlled trial. They randomized folks in the second stage of labor to that extra hour versus the normal 1, 2, 2, 3. And they found that their C-section weight went from 20%, went from 43% in the usual management of second stage down to 20%. Now, you might say, well, that baseline is pretty high, 40%. So, maybe that's not your practice, but still, they showed a reduction by just being more patient and didn't really show any harm from doing that. So pretty impressive that they were able to do this as a randomized trial, I must say. When you look in the second stage, again, there's probably about 10% of C-sections in the second stage occur in the second stage, 120,000. And if you could prevent half of them, again, that's the data, you have a prevention about half, then you prevent 60,000 primary C-sections. And these folks are in the second stage of labor. They already went through that whole first stage. They came in, were triaged at that whole disaster. They've been on your labor for 36 hours, 48 hours. They've really given it the full try. They wanted to deliver vaginally. Give them a chance. Give these poor folks a chance. Let them have their baby vaginally, okay? And we prevent some more C-sections, right? What about operative vaginal delivery? Well, we've certainly seen a large drop, and here's also a drop in episiotomy, which is a good thing. But, and this ends in about 2008. I apologize for these old data. But look, the forceps rates have just plummeted, and the vacuums have gone down as well. And so, the thing about an operative vaginal delivery is we were talking about the number you divert so far, right? Well, with an operative vaginal delivery, the number you divert is essentially 1. I mean, it's 1.1, I guess, because the success of vacuum is about 90%, success of forceps is about 95%. So it's 1.05 to 1.1. But I mean, it's not even 2 or 3. I mean, you can prevent a lot of C-sections. And if you looked at the rates, operative vaginal delivery was about 10% in 1990. It's down to less than 5% by 2005. If you just captured that 5%, you prevent a couple 100,000 C-sections. Okay. Now we're probably doing some double counting here, to be fair, with the second stage stuff and the operative vaginal delivery stuff. So I don't want to cheat, but I'll point that out myself so somebody else doesn't point it out for me. One of the things which I think is not as large as these others, but I think has become an issue, is the management of OP and OT presentation or position, sorry. And we see that, yes, OP and OT lead to longer second stages, increased risk or need for operative vaginal delivery, more third and fourth degree lacerations, hemorrhoids, that sort of thing. But certainly they really drive up the risk of cesarean delivery. And by the way, it's associated with the use of epidural. Epidurals are associated with OP and OT not completing their internal rotation and rotation to OA, right? Well, here's a big study that was, to be fair, a retrospective study. And you can see when in individuals had this is just an attempt at manual rotation, the C-section rate was 9%. These are all in the second stage. And those that were managed expectantly, the C-section rate was 40%. So that's a big difference. It's a 75% reduction. The adjusted odds ratio when you control for confounders was actually 0.12. So that's a big difference. And there is a small prospective trial of attempt versus no attempt. And you can see that in the group that they had some attempt of rotation, C-section rate was 0. There's only 61 patients. And in the expected management is 23%. This is in France, where they do obstetrics, I guess, better than we do. They have lower C-section rates, but 0 versus 23. So it does appear to be reduced by manual rotation. And so, yeah, I mean, again, I don't think this is as big a driver as some of the others, but there's probably 200,000, probably 5% of babies are OP or OT at the beginning of the second stage. I mean, even toward the end of the second stage, actually. So you prevent another 50,000. And again, these are individuals in that second stage of labor. So that management and assessment of the second stage, I think, is very important, very critical. Okay. So, well, all these things we've talked about, are they just going to happen? And the thing is, they won't just happen. We actually have to change our practice environment to allow the obstetricians, the family medicine docs, the midwives, the labor and delivery nurses to practice good obstetrics. And I say practice good obstetrics because one of my mentors in residency, as I was leaving the Brigham, said, Aaron, I just want you to practice good obstetrics, right? And what he meant was these things we're talking about. Be patient in labor, treat individuals as individuals, not as checky boxes, be thoughtful and both prevent injury to the babies, but also let's try not to do so many C-sections. And so obviously I'm joking here about killing people. We don't want to kill any lawyers, but the intent is really that we need to strike down kind of this hostile medical legal environment that puts these bad incentives on us to do a lot of C-sections. And when you look at environment, it really does matter. This is a really elegant paper about 10 years ago now, Health Affairs, that shows the range of C-sections. That in this study, it went from 7% to 70%, 7 to 70 by hospital. And if you get rid of the outliers, it still goes from 15 to 50, right? So there are huge differences by hospital when you look at C-section rates. We looked in California at hospitals that had 24-hour in-hospital coverage versus those that did not, and found that there was a difference in C-section rates, both in nullips and multips, okay? Lower when you've got 24-hour in-hospital coverage, all right? So the ideas behind changing practice environment is mostly conjecture. We don't know exactly how changes in caps on awards and things like having second opinions for all C-sections on labor and deliveries. There's a paper about 30 years ago now that shows a reduction when you required second opinions. We don't really know how they would work today, right? But I would say, let's start doing it. Let's try it and see what happens. Obviously not do it to cause harm to moms or babies, but do it thoughtfully, right? And again, probably not in a threshold punishing sort of way, but in a way to help change our practice environment, because all these things we just talked about, they don't really happen unless we can change the environment. One of the things I've talked about is, what about financial incentives for being patient? What if when someone comes to labor and delivery and their baby's, we assume their baby's okay, they have a normal strip, right? Well, one of the things we should be incentivized for is making sure the strip is still normal. What if we could bill for hourly NSTs or CSTs, right? Then we have an incentive to be up, to be looking at that strip, and we send it off, right? Send it off. Now you've got this incentive to be watching things closely. What if we had increased reimbursement for vaginal delivery? We just talked about it. A vaginal delivery actually takes a lot longer than a C-section. We should get reimbursed for that, right? Or at least, what if the hospital reimbursement was the same, right? They have much more cost for a C-section. What if they're paid the same? Then they would have to figure out, like, I'd really like to reduce that risk of C-section, okay? Well, what's the overall effect? If you add up all those numbers that I listed for you, it's pretty big. It would get us back to a C-section rate of 16%. And I'm here to tell you, I don't mean to suggest that that's ever going to happen. And in fact, we talked about it. You actually had slight improvements up to a C-section rate of about 20%, right? And we did double count a bit, but that's a big difference. That's almost a 50% reduction. And you add in things like second twins and vaginal breaches, which again, I don't think is going to happen. And I didn't even talk about better fetal heart rate monitoring, right? You add in these things, we really could see a reduction in the risk of C-section. I would say, area by area, county by county, hospital by hospital, state by state. We just need to be conscious of it and working together to do it in a safe, thoughtful way. And that led us, of course, to our 2014 document, which is really about primary cesarean delivery reduction, the safe prevention of primary cesarean delivery. And we made a number of recommendations, as I'm sure you all have seen this before. And some of them I mentioned earlier about wait until 6 centimeters dilated for the threshold for active phase, being more patient in the second stage of labor, using operative vaginal delivery, manual rotation, all these kinds of things. Obviously, interesting, the induction of labor we included, that was at 41 weeks, induction of labor, which now people are even doing earlier. But all these things, patience and thoughtfulness is really the key. So I know that I'm a little under time pressure, so I'm gonna stop there. And I think I'm gonna call in and answer some questions. I hope that's what's gonna happen. But again, I wanna thank the organizers for inviting me. It's just been my pleasure. And I hope to join you in person maybe next year or the following year. I was really hoping to come to Tennessee. It's one of my states that I haven't come to visit yet. And so hope to see you all soon. Bye.